Good morning, everyone. Welcome back to Medcomplete Board Review. Our next case is a 42-year-old male with past medical history of rheumatic heart disease who presents to you for the complaint of palpitations that are intermittent and last 2 to 3 minutes. The patient has no other medical history and does not take any medications. His echocardiogram demonstrates normal ejection fraction with moderate mitral stenosis. EKG is shown below. Which of the following is the most appropriate choice for anticoagulation in this patient? Hey everyone, welcome back to Medcomplete Board Review. So the answer to the previous question we posted regarding our 42-year-old male who has rheumatic heart disease is C. This patient should be placed on Coumadin therapy. So in order to get this question right, and this is the type of question that will definitely come up on some of your boards, we have to understand a few things. So the first important thing is to understand the EKG and to be able to interpret it and pick up that this is A.fib. So for those of you on Instagram, if you slide your screen, you'll see a better form of the EKG. But for this, you have to understand that A.fib is irregularly irregular with lack of P waves before the QRSs. So you can see there's clearly no P waves before any of the QRSs. And when we say irregularly irregular, we mean that the QRS, the distance between them is different, right? So if you could see clearly the distance between this and this is different, this and this is different. So that's irregularly irregular, and that means this is atrial fibrillation. So then the next step would be, well, if this patient has atrial fibrillation, does he require anticoagulation? So in a normal scenario, if this guy did not have rheumatic heart disease, his CHA2DS2-VASc score would be 0, right? He does not have hypertension, heart failure, history of TIA or stroke. He is a male. He's younger than 65. All of these criteria. So he would be 0, which would make him, the answer would have been in that case F. The patient is low risk for stroke and therefore does not need anticoagulation. So if you have every single point on the CHA2DS2-VASc score, and what CHA2DS2-VASc tells you is essentially what is the annual risk of stroke. So if we leave these patients off of blood thinners, per year, what is the risk of having a CVA? So if you have every single point on the CHA2DS2-VASc scale, your risk is about 15 to 17% per year, okay? Now, the thing that we want to understand is patients that have moderate to severe mitral stenosis, this by itself is an independent risk factor for stroke with A.fib, and patients that have this have about a 15% risk of stroke per year, irregardless of everything else, if you don't give them anticoagulation. So patients that have A.fib and severe or moderate mitral stenosis, regardless of the CHA2DS2-VASc, require blood thinners. And the blood thinner of choice is Coumadin, okay? It's not that the NOACs don't work, it's that they haven't been tested enough. We don't have enough data to say that they work appropriately. So for patients that have valvular A.fib, which is patients that have moderate to severe mitral stenosis or A.fib with a mechanical valve, those patients should be on Coumadin therapy. Non-valvular A.fib, which means they don't have those two things, they can be placed on a NOAC, whether it's Xarelto, like rivaroxaban, Eliquis, etc. Okay. Aspirin by itself, usually you can give that for patients that have a CHA2DS2-VASc of 1. You can give them a low dose 81 aspirin. Dual antiplatelet does not work. It's been tested. It does not reduce risk of stroke enough and increases risk of bleeding. So the answer here is C. Okay, I hope you found this helpful, and please leave your comments and questions in the section below.